We've all experienced it, that unexpected bill after a visit to the doctor or to a hospital, but it's becoming much more common these days. Rising out-of-pocket costs and other health billing surprises are growing fast, raising concerns among consumers and policymakers about hidden charges that dim the promise of having health care coverage. Good day, I'm Michelle Levander, editor of Reporting on Health. We're going to be exploring today in our Health Matters webinar series, Out-of-Pocket Surprise Costs After Health Reform. We'll be hearing from three distinguished panelists. Larry Levitt, Senior Vice President for Special Initiatives at the Kaiser Family Foundation, will start us off, explaining the trends and why they matter to Americans. Noam Levy, Washington, D.C.-based healthcare reporter for the Los Angeles Times, will share ideas for reporting on the cost squeeze. And Blair Hickman, audience editor for the Marshall Project, a nonprofit news site, will offer her ideas for how to bring alive the stories of ordinary people by using an array of online tools to find and connect with them. Before we get started, I wanted to share a few operating procedures. We'll hear first from all of our speakers, then we'll open it up to your questions for the final 20 minutes. Because we have many people participating in the webinar, we'll ask you to comment in the question field in your control panel, and we'll read out your questions. If you have technical challenges, please also text us through the question or comment field in your control panel. You can tweet about this webinar at the hashtag #HealthMatters, and we will archive it afterward on Reporting on Health. Now let's get underway. Larry, tell us what Kaiser Family Foundation's research tells us about these trends.
Thanks, Michelle. Well, I'm going to start out at the risk of offending all the very knowledgeable folks on the webinar. I'm going to start off just explaining a few terms that I think you probably all know, but just want to make sure, and maybe some of you will learn something here in this quick overview. So first is a deductible, and I think most folks understand what this is. This is what you have to pay up front before your insurance starts paying for services. A couple things to remember about a deductible. One is that it may not apply to all services. So for example, drugs or physician visits may be covered even before the deductible is met. And there could be different deductibles for different services. There might be a deductible for drugs, which is reasonably common, that's separate from a deductible for everything else, or a separate deductible for hospital services. Then there are co-pays and co-insurance, and this is what you pay when you go to a doctor, fill a prescription, or go to the hospital. These are commonly confused. A copay is a dollar amount you pay, $20, let's say, for a physician office visit, and co-insurance is a percentage, let's say 20% of the cost of the visit. There may also be out-of-pocket costs that vary by certain tiers, and these are commonly applied to drugs, although maybe applied to other services as well. Most typically in drugs, there might be one tier or one level of copayment or co-insurance for generic drugs, another for preferred brand name drugs, another for non-preferred brand name drugs, and increasingly a separate tier with higher co-insurance for so-called high-cost or specialty drugs. Also, typically insurance plans have an out-of-pocket maximum. In fact, under the Affordable Care Act, all plans have to have an out-of-pocket maximum of no more than $6,850 for an individual or $13,700 for a family. And this is the most that an individual insured under the plan would have to pay through the combination of deductibles and co-payments. One important thing to keep in mind here is that in ACA plans and in general, these out-of-pocket maximums apply only to in-network services. So if you go out of network, if the plan allows for out-of-network services, there could be much higher costs. Now speaking of out-of-network services, another type of expenditure that consumers are vulnerable to when they use out-of-network services is balance billing. And this is when a provider bills more than the insurance plan, charges more than the insurance plan pays, and if you're using an out-of-network service, you may be subject to that, the difference between the charge and what the insurer pays. And I'll talk a little bit more about this later when we talk about surprise medical bills. Now, specifically focusing on ACA plans, one of the things the ACA did was standardize coverage into so-called metal tiers in the individual market and the small business market. These tiers are bronze, silver, gold, and platinum, and what they do is standardize the generosity of the the coverage through something called the actuarial value. And as an example, what that means for a silver plan, which has an actuarial value of 70%, that means on average the insurer pays for 70% of covered services, and the individual pays for the remaining 30%. That will vary a lot from individual to individual depending on their circumstances and their healthcare needs, but on average it's a way of standardizing the generosity of plans. And then finally, another element of the ACA is a requirement on all plans that they have a summary of benefits and coverage, which is a much more consumer-friendly description of what the plan covers. It's not perfect, but certainly better than what commonly existed before. So now to give you a sense, I mean, so there's this whole range of out-of-pocket costs that a consumer might face in an insurance plan. We often focus on the deductible, and I'll be focusing a lot on the deductible because it's easy to think about. But in fact, the deductible, it's important to remember that the deductible can be a little bit deceiving. And what you see here are two plans that are being offered for 2016 in the marketplace in the state of Washington in Seattle. And these are two plans that are offered by the same insurer, Ambetter, and are both silver plans, so are theoretically standardized to the same basic level of generosity, although there's a little bit of wiggle room in that definition. The premiums are similar, although the premium in the second plan in the second column is a little bit higher. And what you can see if you just looked at the deductible in these plans, you would get a very different view of the generosity. The first plan has a deductible of $5,000 per person, $10,000 per family. The second plan has a deductible of only $1,750 for an individual and $3,500 for a family. But when you look more deeply at the plan, you can see there's some other big differences. Probably the most major difference is that in the first plan, the deductible, that $5,000 deductible applies to drugs, so you don't get any coverage for drugs until you meet that deductible, whereas the second plan has a separate $1,000 per person deductible for drugs. So it's just a reminder that while the deductible is an indication of the generosity of a plan, it's hardly a perfect indication. But as I said, the deductible is the easiest thing to measure over time, and it does give a sense of how plans have been changing. And this shows how deductibles have risen in employer plans over time, and this is a trend that certainly predated the ACA. Deductibles have doubled over the last 8 years, and now average for those plans with a deductible, which is the vast majority of plans, over $1,300 per individual. And this is another way of looking at that, which is what percent of workers enrolled in a plan have a deductible of $1,000 or more. And as you can see, that's now become the norm in general. And in fact, there are big differences in the generosity of coverage offered by small employers versus large employers. Well more than half of small employers now offer a plan with a deductible of $1,000 or more. Now this really tells a story of why even in a period of relatively slow growth in healthcare costs overall, people themselves are feeling the pain of out-of-pocket expenses. Deductibles over the last 5 years, just over the last 5 years since 2010, have risen 67% in employer plans. Premiums, so the insurance side of insurance, premiums have risen just 24%. So that gives you a sense of how insurance has gotten less generous, and while there are relatively slow growth in premiums, a lot of the expense has been shifted to patients in the form of higher deductibles. And even more significantly, worker earnings have been almost flat, rising only 10% over the last 5 years. So it gives you a clear picture of why workers are feeling the pinch from out-of-pocket costs, seeing rising expenses as their wages are stagnant. Now turning to the ACA and the plans that are being offered on the marketplaces, this gives you a sense of what these plans look like. There's a lot of variation around the country and a lot of variation from plan to plan, as I showed you initially, but this gives you a rough sense of how these metal tiers stack up in terms of generosity. Bronze plans are very high deductible plans, essentially catastrophic plans with an average combined medical and drug deductible of over $5,000. Silver, sort of the mid-range plans that are quite popular, have a deductible still quite high of over $2,500 per person. And when you look at gold and platinum plans, which are more similar to what employers offer, you can see deductibles that are quite a bit lower. Now, one thing that I think gets lost in looking at these deductibles and ACA plans is the fact that lower income enrollees, which are most of the enrollees in the marketplaces, also receive cost-sharing subsidies in addition to the premium subsidies they get. And this gives a sense, again, there's a lot of variation from plan to plan and market to market, but this gives a sense of the value of those cost-sharing subsidies. So you can see a standard silver plan has an average deductible of about $2,500. Someone who has income between 200 and 250% of the poverty level has that deductible reduced to about $2,000. Someone who has income between 150 and 200% of the poverty level has a deductible reduced to $700. And for very low income enrollees, those with incomes under 150% of the poverty level, the deductible average is about $200. Now, stepping back a little bit, I think it's important to think about why cost-sharing insurance matters and what its purpose is. You know, certainly it's pretty obvious, I think, but cost-sharing lowers the premium by decreasing how much the insurance plan has to pay for services, or looking from the perspective of the patient, shifts costs to the patient. It also focuses insurance on, you know, particularly the deductible, focuses insurance on high-cost, unpredictable expenses, which are really the main purpose of insurance to begin with. Cost-sharing in general and deductibles in particular also decreases health spending overall, not only by shifting costs to patients, but by encouraging patients to obtain fewer services. And there are many years of research dating back to the Rand Health Insurance Experiment that show that when patients face higher cost sharing, they use less care. And they use less care that's not only care that's not effective or valuable, but also care that would be of medical value to the patient. So it's a bit of a crude cost containment mechanism. Finally, cost sharing also provides incentives, depending on how it's designed, to obtain the most appropriate or cost-effective care. A good example of that are the tiered drug formularies, where they encourage patients to use lower-cost generic drugs, and those have been quite effective. Now, it's also important to look at the how much money patients actually have to meet this cost sharing. And you can see an example here of looking at the assets of typical households and whether they have enough assets to meet a deductible. Looking at all non-poor households and a typical deductible of $1,200 per person, about a quarter of households overall would be unable to meet, would not have liquid assets to meet a deductible of $1,200 or more. And if you look at lower income people, in fact, the majority of people would not have liquid assets to meet a deductible of that level, or really any kind of financial emergency. Now let me turn quickly to surprise medical bills. And these have gotten a fair amount of attention lately. So the typical scenarios for a surprise medical bill, there are really two. One is someone who goes out of network, out of their plan's network for an emergency, and faces balance billing for care they received during that emergency. If it's an emergency under the ACA, they can't be charged higher cost sharing, so higher copays, for example. But if the providers that care for the person are not part of the plan's network, the patient may be subject to balance billing. The second kind of situation, which I think really sort of perplexes people, is where someone receives care at an in-network facility. So they follow all the rules, they go to an in-network hospital, but they're treated by physicians or other providers during that stay at an in-network facility who do not participate in the plan's network and balance bill for services, and the patient would also face out-of-network cost sharing. So typical examples of this might be someone who goes in for surgery and the anesthesiologist is out of the plan's network, or receives a lab test, and the lab that performs the test is out of the plan's network. There's been some activity at the state level and proposals at the federal level and on the campaign trail to deal with this. Probably the strongest law is one that went into effect this year in New York, which just very quickly requires in-network cost sharing and no balance billing for surprise bills. There's an independent dispute resolution process, which really gets to the key of this of the challenge in preventing these surprise medical bills, which is, if you're going to protect the patient, who ends up being responsible? Does the plan have to eat the cost? Do doctors have to eat the cost in terms of lower payment rates? And what do you do about disputes between those plans and doctors? Now let me just conclude with a brief mention of the Cadillac tax. As I said, the trend towards higher cost sharing has been going on for a number of years, but the Cadillac tax, which goes into effect in 2018, could really accelerate that trend. What the tax does is applies a 40% tax on any plan costs in an employer plan in excess of certain thresholds. Those thresholds are $10,200 for a single person, $27,500 for a family, and the thresholds increased with inflation, which is far lower than what premiums have been increasing at. And the general assumption is that, the hope is that employers and plans will meet these thresholds by finding a more efficient way to deliver care, but I'd say the general assumption is that the main way they'll be meeting the thresholds is by lowering the cost of benefits through increased cost sharing. And this just gives you a sense of how that might play out. These are some recent estimates from us that show that about a quarter of employers, when the tax takes effect in 2018, would have some plan that exceeds the thresholds. But because premiums are expected to rise faster than inflation, the percentage of employers rises with time, and so by 2028, after 10 years, 42% of employers would have one or more plans that are subject to the thresholds. So, I think the Cadillac tax is going to be one of the biggest health issues facing the next president, and this debate is really going to hinge on the cost-containing pressure that the tax would impose, and the flip side being higher out-of-pocket costs that patients may see.
Thank you, Larry. That was really excellent. Noam, tell us how reporters can tell stories about all this.
Sure. Can you see my? Oops. Second. Okay. Can you see my screen? I hope. So I'm gonna run through a few storylines that I'm interested in at the moment as they relate to cost sharing, and I'll say from the get-go that I'll refer all technical questions about some of these issues to Larry, but I think one of the things that's interesting about what's happening with increased cost sharing is that it increasingly appears, based on polling that Kaiser and others have done, that Americans are singularly focused on this issue above almost all others in healthcare. So while the national political debate may be about the Affordable Care Act, Obamacare, and so forth, and repealing it, or Medicaid expansion, or the other kinds of health policy issues that many of us who cover healthcare write about, for most Americans, kind of what their premiums look like, what their deductibles look like, what the surprise bills and prescription drug prices look like are much more substantial. So I'm going to run through, as I said, a few storylines that I think may be of interest, may be worth sort of tracking. The first one has to do with variations around the country, and I would recommend this to folks who are working in local markets around the country, because the cost sharing story, while it's uniformly sort of looking bleaker and bleaker for consumers, is having a greater impact in some places than others. And this graph here, I think, is interesting to the extent that it shows that the average single person deductible, varies by a factor of 3 across the country, with some states having very high deductibles, others much lower. And this, Larry could probably talk much more knowledgeably about this than I can, but largely reflects the different kinds of employer markets that exist around the country, different kinds of regulations at the state level, and may, I think, kind of tell an interesting story for readers about what some of the solutions may be, in the sense that some states may offer some solutions for other states where the out-of-pocket costs are much higher. I'll show you another slide here that touches on this geographic variation, and both of these slides, by the way, are taken from a report that the Commonwealth Fund did last year, or earlier this year, I guess it is, that looked at some of this geographic variation at the state level and the cost of employer health insurance coverage. And I would refer it to folks, there's some really, really interesting data in there that is downloadable and can be searched. Looks at employer and employee contributions to health costs state by state, and can be quite illuminating. Here, I just want to bring this up as an issue to keep your eye on. You'll see that, particularly, let's just look at 2013. Things have changed since 2003. But one thing the Commonwealth has done in some of its data analysis, which I think is interesting, is to look at not only what employee costs and employer costs are doing relative to state to state, but also what those costs are relative to the median income. So we know, for example, that healthcare costs are much higher in a place like Massachusetts or in the Northeast than they are in the South. But if you look across the South, one of the interesting things here, I think, is that when you put together what healthcare costs relative to what people are actually earning, the affordability issue actually may be more intense in a place like Texas than it is in Massachusetts, even though absolute costs are higher in Massachusetts. So I think that's something to keep an eye on, and particularly for reporters who are in states where incomes are lower and where the affordability issue actually may be more acute. It's something to pay attention to. Some of the other data that's really interesting in this Commonwealth report that I referenced allows you to look at what the employee share is of premiums around the country. And again, it's interesting to look when you look at the states that have the lowest employee share of health insurance. You can be looking at, in Hawaii's case, less than 10%. Less than 10% of the cost of an employer-provided health plan in Hawaii is borne by the employee. Whereas in some higher cost states, in some sort of more, I don't know if we should say skimpy states, you can be as much as a quarter of the total cost of the health insurance plan is borne by the employee. So again, I would really recommend this report as something to look at to sort of identify in your state what is the picture in terms of what is the employee bearing in terms of deductibles and in terms of premiums. One other storyline which I don't have any data on, and I only have some anecdotes to share with you, but I think it's something that it bears following. We're seeing increasingly polls of physicians and hospitals showing concern about the rising deductibles and the rising out of cost that patients face. Many doctors and hospitals are saying they're concerned about seeing patients coming in sicker, coming in later, et cetera. The emergency room physicians just released something. It wasn't a scientific poll, but it pointed to this. But another angle that I think is worth keeping an eye on is what the impact actually will be on the bottom line of medical practices around the country. And this can be of particular interest in communities where there may be limited numbers of hospitals or medical practices. I was chatting with a very successful, historically very successful medical group in the upper Midwest recently that sort of traditionally has scored very well on a lot of measures of quality and efficiency and so forth, that's been struggling mightily to balance their books. And they attribute part of this to the fact that as deductibles have risen, people are coming into the doctor less frequently, and that's a lot less income for the medical group. So I would encourage folks to keep an eye on this in their market, see what the impact is on the medical practices and so forth, and hospitals. Touch a little bit here on something that Larry talked about, which is what some of the potential responses are. The New York Times did a terrific series over the last couple of years looking at some of these issues of surprise medical bills and affordability, and it has in fact sparked a lot of interest around the country in trying to figure out a regulatory response to this. Now, a lot of states have had for many years laws on the books that sought to regulate balanced billing in one form or another, but I think there's a pretty widespread feeling among consumer advocates and others that the protections are inadequate. And New York, as Larry mentioned, passed a law that went into effect earlier this year that attempted to put some new protections in place. Connecticut did the same. Interestingly, these protections are almost as complicated as the problem they're seeking to resolve. They don't ban this practice entirely, but rather set up systems for arbitrating disputes, which may reflect in part the complicated politics involving insurers, involving provider groups, and so forth. California is Texas, I'm sorry, is a place that that has passed some more limited protections. In this case, just related to emergency care. A number of other states here, California, Pennsylvania, New Jersey, Georgia, and Florida, have sort of active discussions underway. California, interestingly, tried to pass something that that died in the legislature, in part, I think, because there was some lobbying by medical groups who take issue with any kinds of limits on this kind of billing. So I think this is something to definitely keep an eye on, even if you're not in one of the states that that I've colored in here. Consumers Union, which is taken a real lead in kind of going after some of these issues and pushing for regulations, has some terrific resources. Here's the link to it, which I think you guys should be able to access off the slideshow. I recommend getting in touch with them. Another trend which is developed to sort of respond to some of the balanced billing is the development of different kinds of insurance plans, sometimes called value-based insurance design. And the advocates of this kind of policy response, there's some folks up at the University of Michigan who are very passionate advocates of doing this, argue that just having high deductibles is a really blunt instrument, because it just stops people going to the doctor when they need to go to the doctor, as well as going to the doctor when they don't need to. And across the country, we're increasingly seeing larger employers begin to experiment with ways to incentivize folks to get the care they need by lowering the deductibles and lowering cost sharing for needed services. So, for example, maybe for folks with diabetes who clinically we want to go and get their regular checkups, get their eye exams, get their foot exams, etc. You don't want to put barriers for them to go to the doctor. So maybe there are those kinds of visits are exempt from copays. Other ways that large employers are thinking about doing this involve lowering cost sharing for the use of high quality hospitals or high quality physicians. This movement is I think still in its early stages. These figures which I'm showing you here are drawn from an annual survey that the National Business Group on Health does of about, I think, 150 or so large employers. So this isn't representative necessarily of the entire employer community around the country. Large employers are obviously much better positioned to try to dig this deeply into designing their benefits in a way that are not standard. This will be much harder to do, obviously, for smaller businesses. But in all the talk about narrow networks and so forth, I think there is an emerging conversation to keep an eye on in your area about are there employers that are trying to figure out ways to reduce the cost-sharing burden on their employees in a way that has the added benefit of increasing health. As you can see here in this slide, it's still a pretty small share of the of even the large employers that are doing this, but you are seeing more and more of it. This is another kind of value-based design, which, as I said, identifies so-called centers of excellence. Walmart has actually, interestingly, experimented with this, as have some other large employers like Boeing, trying to provide financial incentives if, for example, their employees go get heart transplants at Cleveland Clinic rather than at the local hospital where outcomes may not be quite as good. I'd refer you to the VBID Center, which is at the University of Michigan. They have not only a wealth of information about the way that benefit designs are being tinkered with, but also can provide lots of examples in your market for employers that might be worth checking with to see how this phenomenon is unfolding and what the experiences they're having with their employees and with cost sharing. So I'll leave it there. Thanks.
Thank you so much, Noam. This was so helpful. Blair, tell us how reporters and others can find the real people who can make these stories come to life.
As soon as I get my presentation full screen, I will do just that. Can you send me to share your screen again, please? Are you guys seeing it?
We're having a little problem with that. Do you want to just start speaking, and we can try and get that up momentarily?
Sure. So what I'm going to talk about is building off of Larry and Noam, and goes into how to find communities, engage them, and organize people so that you get a unique source database that gives you insight into kind of what's going on the ground with the issue that you're covering, which right now is out-of-pocket costs. The goal is that you find people that other people haven't talked with yet. You hear their stories and get new story ideas, and also end up building a support and ambassador network for when your stories actually do launch. Just one second. So, hello?
Yeah, we're still trying to get your PowerPoint up.
My computer keeps freezing. Can you guys see my screen now?
Yes. So Blair, now we can see your screen.
Okay. See that?
Yes, we can see everything you're doing.
Okay, excellent. Okay, so everything I just said, I did while at my last job at ProPublica, where I was working with Marshall Allen and Olga Pierce on what became their surgeon scorecard. So if you guys want to go deeper into this technique of engaging with communities to find a specific story, you can go look at their patient safety page, and it'll have more explanations, deeper explanations on how to do that. But the basic tenet behind this engagement process is to make what we call a call out. This is just sort of a fancy name for an online questionnaire that you can sprinkle around to sources that you meet online, sort of like you would ask questions to sources that you meet in person or pick up the phone. There should be a link in the chat window to one of the call-outs that we made for this patient safety organization. The most important thing when you're making a call-out and think about making a good one is to think first about who this is affecting. So not necessarily the topic that you're covering, but really kind of a sketch of the person that's going to experience this problem. So maybe it's, you know, the poor, maybe it's freelancers. It could really go either way. You also want to give people a little overview of why this issue matters, who's affected, how big it is, because you want them to feel like they're participating in sort of a bigger issue, like they're a part of a community. It's a kind of engagement incentive trick. In terms of question design, if any of you are scrolling through the call out on the ProPublica website, one thing that's really important when you're constructing online questionnaires is to make the questions as structured as possible. And I know there's a line here that says open-ended question, but we'll get to that in just a second. And the reason is, one of the goals in doing this online call out is volume of responses. You know, not only, you might find that golden story that ends up becoming a feature character for you down the road. But as people start to fill out these answers, you're also going to get a big picture view of the landscape of this issue. And you might find story themes that bubble up that you hadn't thought of before. But that's going to be very difficult if all of the questions on your form are open-ended paragraph text boxes where people can just type in whatever you want. So you want to get really specific when you're thinking about what questions you want to put on your call out, and make as many of them open choices, as structured as possible, multiple choice boxes and that kind of thing. So I think one of the questions on this, have you been harmed in a medical facility, asks what kind of facility did the harm occur in, but instead of having a box where people could type in whatever they wanted, we gave them 3 or 4 choices that said something like hospital, doctor's office, nursing home, and people could just select one. So that makes it easy on the back end to sort and filter the data. One of the easiest tools for building these callouts is Google Forms. It's free. It's nice because you can share the back-end data, so when somebody answers it, it goes into a spreadsheet that only you have access to. It just goes into a Google Sheet, and then you can share that Google Sheet either with your editor or other reporters if you're collaborating on a project. So it's really nice for working within newsrooms. This is an example of a good way to structure your questions. So instead of outcome of the harm, you know, if that had been an open field text box, we would have gotten essays, many essays that would have been almost too difficult to sift through. So instead we gave them 3 options. And once you get a certain volume, you're going to start to notice themes and areas that you might want to dig deeper into. So once you've constructed your call out, then you want to go find the people that are affected by whatever you're covering. And this is the point where you really need to think about who you're targeting rather than just the topic. So even though this is a healthcare issue, you might not be looking and Googling for healthcare forums. You know, you might want to approach your local freelancers union, for example, and say, hey, do you guys have an email listserv? I'm working on this thing. If you think that people would be interested in participating, like maybe you could send it out. There should be some links in the chat box right now to a couple of groups that I know about that already exist that are pretty useful. One is this screenshot that you're seeing, which is the New York Times' Facebook group that they made around the Paying Till It Hurts series. I'm not actually sure if they're still publishing within this series, but the group is still very active, and most of the conversation seems pretty articulate and intelligible. The second link is to ProPublica's patient harm series, or patient harm Facebook. Again, that series is up, but they're still reporting on the issue, and that group was actually designed so that other journalists could come in and learn what's going on. When you do find a new community, and you can find these by talking to people, asking your existing sources, Facebook is really great for general communities. LinkedIn is really great for professional communities, which brings up a point that I wanted to make. Either Noam or Larry mentioned that a good story idea might be the effect on doctors. One thing you want to think about with callouts is it's best to target your audience as specifically as you can. So if you want to know what happens on the consumer side with these rising healthcare costs, you might design one for a healthcare consumer, but you want to design a completely separate call out for providers. That one, I feel like, especially with healthcare providers, it helps if it's framed as, we want your expertise, join our advice network, or something of that sort, and you invite them to just participate. Ask them about their area of expertise, ask them about the state that they're in, because all those things are going to link to your story ultimately. And if you can get some of that information up front, that will cut down on the reporting that you have to do afterwards. But the second reason that you might want to create two is oftentimes these two audiences might live in different places online. So LinkedIn, for example, has many more professionals in healthcare and beyond. So if you're ever looking for experts, that's often a great place to go. But Facebook, as I was saying, is more for the general audience. So that might be a great place to go find communities to engage with that are more active healthcare consumers. Once you find these communities, it is important, I think, not to just parachute in. There is some online etiquette towards approaching these people. It's sort of like meeting a person in real life. They have no reason to trust you on the outset, and you need to kind of show them your personality and gain their trust before they're going to share their story. It's sort of similar in online communities. You can participate. I would recommend participating on a semi-regular basis. You don't have to be a daily active member of a group, but if you can get in and start liking things or commenting or asking questions. If you're on a shorter deadline, one thing that I like to do is message the group's moderators. Often in an about page, it'll say who runs the group, and you can either, if it's on Facebook, you can Facebook message them. If it's on Reddit, you can send them a message there, and just be really upfront and transparent about who you are and what you're trying to do and what information you're looking for. A third thing that'll be really helpful is build this community and try to, I don't want to use the word peddle because that has such a negative connotation, but as you spread your call out throughout the internet, is to create content as often as possible. I don't know anything about the kinds of stories you guys are working on, but for us at ProPublica, we were doing very long investigations that were sometimes, you wouldn't publish anything for a year. In this patient harm case, it was even longer than that. So we had to get into the mindset of, okay, we're going to, tell people what we're working on in a vague term, and then create little pieces of content almost for the community. So if you're seeing that people consistently have confusion around some aspect of out-of-pocket costs, but it might not be a news story, maybe you can do a Q&A with an expert. And it's creating content like that that provides value to the people you're trying to reach that's going to pull them to you. So eventually, you'll be the go-to person for when they want to share their out-of-pocket healthcare story. And if they like what you're doing, eventually, if you have an ask, if you say, hey guys, I shared this story, or I just wrote this story, would you mind sharing it? They might be more apt to do so. That is a super quick overview of this process. I just wanted, before we leave, to kind of make you guys aware of two other kinds of crowdsourcing projects that I personally think would be interesting through the lens of out-of-pocket costs. And that's this idea of using the crowd to help you dig through documents. For almost everybody, this is really only going to be possible with newsroom resources, particularly interactive and dev resources. But there are two places that do this really well, this style of crowdsourcing project. One is the New York Times, and they have this product that they've open sourced called Hive that basically lets you put a bunch of documents on the internet, and then people go through and pick out bits of information. So they did that for a project called Madison, which went through their advertising archives and had people go through, and you said, give me a snippet of the paper, and then they would go through and say, this is one ad, this isn't an ad, this is multiple ads. So in that way, it helped organize what was in these massive data sets. We did it again. Again, this is a ProPublica project called Free the Files, and this one was with FCC ad buys. But what I think would be so interesting is to get a deeper look at people's medical bills. I'm not sure with HIPAA requirements exactly how far you could go, but I wanted you all to just know that this kind of project exists, and if any of you are in newsrooms with these sorts of resources, maybe you can brainstorm about it, and I'm happy to chat more in depth off of this panel as well about how this would work.
Thank you so much, Blair. We're now going to open it up to questions, and just a reminder to everybody that you have a control panel on your GoToWebinar screen, and you can type in questions, and we're going to ask them of our panelists. So I'm going to start out with a question from Don Sapatkin, who asks, could you review in a little more detail the out-of-network issue in emergency care? And maybe, I don't know, Larry, you want to take that one? Or
Sure. So, so the issue is, and just to back up, and I think I mentioned this, that the ACA requires in-network cost sharing in an emergency, even if you use an out-of-network provider. So that sounds like sufficient protection for people, but the problem comes in with the balance billing, it's even more an issue than you might even think, because there are real issues with getting emergency room providers, or in a really serious situation, neurosurgeons, to participate in plan networks. And it's really, and Noam I think described this well, but there are the real challenge here is how you deal with payment disputes between the plan and the provider. So even if a state, if policymakers wanted to protect patients and say that the patient cannot be subject to balance billing if they use an out-of-network provider in an emergency, the nub of the problem is how do you deal with those payment disputes? So the plan says, okay, the plan has no contractual relationship with these providers, so is going to try and pay as little as they can. The providers are going to charge as much as they can, and if you're holding the patient harmless, how do you deal with that? So that's why in these surprise bill proposals in Texas and in New York, which have passed laws, the really contentious issues come down to how to resolve those disputes, and that's what's been, I think, stalling the legislation in California. I think there's a pretty broad consensus that patients should be protected. The question is how to deal with those payment disputes.
Thank you. We have a question from Bram Sable-Smith. Are there data comparing the high deductible plans in urban versus rural areas?
I'm not aware of anything, and I think one thing, Noam's data was from the Commonwealth Fund is interesting. That comes from the MEPS survey, federal survey, and there are a number of factors that lead to kind of typical deductibles in each. And I mean, some is just the labor market, sort of how much power workers have versus employers in labor negotiations. But there's also, how high healthcare costs are in general in low healthcare cost areas. Deductibles are typically going to be lower as well. But it also has to do with the insurance landscape. So areas where HMOs have a much higher penetration are typically going to have lower deductibles because HMOs are just less likely to have big deductibles than PPOs or traditional insurance plans. So there are a lot of different factors. I mean, rural areas tend not to have a lot of HMOs just because of the nature of the healthcare market. They are often lower income and lower healthcare cost areas, though, so that will lead to, in some cases, lower deductibles.
I wonder, Larry, I don't know what you think about this, but it occurred to me that the ACA marketplace plans are obviously a relatively small subset of all of the plans, but if someone was so inclined, one could sort of look by rating area around the country, and some rating areas are going to be more rural than others, and you could sort of look at what the deductibles look like in the marketplace plans in the different rating areas. Although I don't know, maybe that may be the way to go about it because of the bronze. The natural division among the metal levels. I don't know. That's just a thought.
Yeah, no, the standardization makes it hard, and you also, I mean, one, and I, certainly there are a lot of journalists around who are annoyed about this, but there's very little data out there about by area which plans people are choosing. But if you had that data, then you could actually do a lot of interesting analysis of what things look like by area.
This is a great example of when a call out might come in handy when data doesn't exist really. So if it's structured in such a way that you have enough information about this person's income, their healthcare options, what their deductible is, and then of course ask for their contact information so you can follow up. It's one way of assembling the data. So when we were doing it at ProPublica, I think when we got to 600 answers, our data scientists said that was of statistical significance. And one way we've been doing it at this job that could maybe work for these rural areas is to approach the paper there in those areas and partner with them on a data collection project.
We have a question from someone named Colin Roysh that may address this issue. He asks, shouldn't enrollment data by plan ID be available from HHS?
Yes.
So that might help with, targeting a rural area.
Maybe it should be, but it's not.
Right.
So I'll go on to the next question. This is from Julie Silas at Consumers Union, who asks, are there any plans that have separate deductibles for out-of-network costs?
Absolutely, and in fact, it's reasonably common. And there's also, there are, I think there are some transparency issues here as well. For example, in Covered California, I've not been on their shopping tool this year, but last year it was very hard to find out what out-of-network costs look like. I would also say, and there's been some good reporting on this out of Texas, but there is, I think increasingly plans with any out-of-network care available have been disappearing in the individual market and the ACA marketplaces. Increasingly, we're seeing only HMOs and what are called EPOs, which were actually not a very common type of plan, but are now pretty common in the marketplaces. And those are like a PPO plan, except there's no out-of-network option.
There was an interesting, I'm sure Larry, you saw this interesting little research study in JAMA this week that actually indicated that there are some specialists that are entirely missing from some of the plans that are on the marketplace now. They're so narrow. So it's a problem.
We have a question from Kathleen Foodie, who says, as state legislatures start to discuss surprise billing, how should reporters evaluate those proposals?
I think the consumer advocates, I think, are a good place to go. Frankly, in many cases, they're driving the effort to advance this stuff, and I think can be the check. The other interesting party that I would keep an eye on are the insurers, because one might be sort of tempted to think that, well, insurers don't want to necessarily get behind more regulations and so forth, but in some cases at least, I think some of the insurers have actually been more open to sort of viewing, to structuring some kind of workable solution here than you might think, because this is becoming a headache for them as well.
I would add to that the physician groups as well, particularly ER docs and specialty groups. I think it's really tempting in situations like this to make insurers the villain, but as Noam says, it's not always quite that simple on this issue, or any issue for that matter.
So I don't. Well, I was just going to add. Larry, I'm curious what you think about this, but my sense is that in many cases, some of the medical specialties actually are building their business model around balanced billing. And this is, in fact, I think one of the more problematic parts of the issue that is worth focusing on, because ER docs, neurosurgeons, in some cases, in some of these debates around the country, I think have been pretty explicit about saying that they can't afford to stay in business, they can't afford to keep service in emergency rooms, unless they're able to collect these much higher reimbursements for out-of-network charges. So that argument is sort of, on one level, is kind of repulsive. On the other hand, the argument that it's difficult to find staffing for emergency, especially emergency specialty care, is a much broader issue than just what the individual specialists are looking at.
I would completely agree. For emergencies in particular, there's no contractual arrangement that kind of deals with how much a plan should be paying, because by definition there's no relationship between the plan and the physician. It's even more extreme when it's out of area, when it's out of state. So these are very, very tough issues.
Can I just add one other thing really quickly? I mentioned this JAMA study, and what the researchers there did was pretty simple. And actually, when I read the study, it made me think it's something that would be a good reporting project. But the researchers just pulled a group of health plans from the marketplaces in the states that are using healthcare.gov, and they went through the provider directories and looked at a group of, I think, 8 or 9 specialties to try to find out if there were any specialists in the various different specialties in this directory. And this is going to become easier as these plan directories become more interactive. But it is something that I think reporters would actually be ideally positioned to do, to actually check the adequacy of these networks. Because, I mean, if there's no psychiatrist or if there's no endocrinologist in a health plan, that's not necessarily something that the consumer would know when they're signing up for a plan, if they don't necessarily think that they need, an endocrinologist. So I think that's actually something reporters could very easily do in their area, is check the adequacy of these networks.
So I just wanted to mention a couple of things here coming from some of the questions and comments. One is that Consumers Union is collecting stories on out-of-network billing from consumers, which could be a resource for reporters. And then Clear Health Costs is doing a kind of crowdsourcing project in partnership with a number of media outlets. And Jeannie Pinder, who founded that, has asked for your critique on it. As you all know, with the crowdsourcing, it's not going to be really controlling for different kinds of variability of how people report these things. So what's being served by these kinds of experiments?
I think, this is Larry. There are a lot of issues that are very hard for analysts like me to tackle because the data aren't easily or readily available. And so I think those kinds of crowdsourcing projects are a great way to surface issues and certainly to surface anecdotes. I think it's really important to be careful that they, in terms of how they are presented and how that they're reported, since they're not randomly drawn samples, and you can't necessarily generalize from them. But I think they're great tools for reporting, and in many cases can go beyond what the analysis that folks like I can do. And I think Noam's example is a great one as well about networks. I mean, it's very hard. I think we'll get better data, hopefully this year, to do these kinds of plan network analyses. But it's very hard for a research organization to do all the legwork and to really understand the local geography of a market. But a local reporter, I think, can add a lot by doing something like that.
Blair, did you have any thoughts on these crowdsourcing projects? And I mean, you're doing these all the time in terms of how you assess and report on what you're finding.
I think Larry covered it pretty well. I mean, the other thing is it exposes you to such a wide array of experiences and stories that in the end the journalism really becomes a bit better because of it. I think another good thing is if you do a good job of building a community around it, it sort of serves two additional purposes. So like not only are you amassing the data that can then be passed along to researchers or used in your own reporting, but communities around certain issues can also kind of become valuable in and of themselves as community members connect with one another and provide each other with advice and resources. And so in that way, it sort of amplifies the impact of the journalism that you do. And in the same way, if this community is engaged and loyal to you, they serve as little ambassadors. You know, it's a little marketing term, but if you're collecting email addresses as you build this source database, then every time you publish something, you can email them and say, I thought you might be into this. If you want to share, please do. And that's one of the most powerful ways to get your work out there.
Great. Thank you so much, Blair, and thank you, Larry and Noam. This has really been a very engaging and informative discussion. This is Michelle Evander from Reporting on Health. We're going to end our webinar now, but I wanted to remind all of you that we'll be sending you a survey shortly just to ask for your feedback. This really helps us in designing future webinars, so please take a moment to fill it out. Thank you again to our panelists and our audience.